And now to introduce Dr. Leroux. Dr. Leroux is a neurologist and headache specialist. She currently practices at the Brunswick Medical Center Glen Neuro and is a faculty lecturer for McGill's Neurology Department. Dr. Leroux completed her neurology training at the University of Montreal and her headache fellowship in Paris, France. She directed the University of Montreal's headache clinic from 2010 to 2016, then the CHAMP multidisciplinary program of the University of Calgary from 2017 to 2019. Dr. Leroux is past president of the Canadian Headache Society and the founder of Migraine Quebec and founder and previous chair of Migraine Canada. She's a well-known speaker for all audiences interested in learning about headache medicine and science. Dr. Leroux is passionate about education and advocacy for headache disorders. Her particular interests include multidisciplinary and holistic approaches, the impact of migraine in the workplace, vestibular migraine, and cluster headache.
So good evening, everybody. Welcome. Thank you for your interest in this webinar. I'm very excited and I'm very happy to be here with you tonight because this is big. This is like a big piece of literature of science that I'm sharing with you tonight. And so I will present over the next approximately 40 minutes. The first part will be a bit more basic and then we'll go more complicated as it goes and more advanced. So I hope it will be useful to you. And you will ask your questions at the end. Okay, so we're going to talk about the updated Canadian Headache Society Migraine Prevention Guidelines. This is actually a screen capture of their website. So this is really an important event for the headache community in Canada, and I will say the world because, to be honest, Canadian guidelines have always been recognized as high value in the headache community worldwide. Those are my own disclosures. So I do work as a consultant and speaker for different pharmaceutical companies. All of these companies have something to do with migraine, so they might be relevant to some products that I will name or present tonight. And I'm also in favor and working with Migraine Canada, Migraine Quebec, and the Canadian Headache Society. Okay, so the first thing I want to tell you about those guidelines is that you have access to them. You can go, and if the fast way to find them is to Google CGNS migraine guidelines. So CGNS is the Canadian Journal of Neurological Sciences, and it is free access. So I say this because you can actually spread the word right around you or share this with your healthcare provider or anybody who might have interest. And it's very important to us that this document was free access. This is a 23-page document. There's 161 references or medical references, and you can see it's been a team effort by multiple members of the Canadian Headache Society. And it is actually, there's way more pages of tables and analysis tables that are more data related. So that's the document we're discussing tonight, and you can actually have full access to it. So what are guidelines exactly, right? And you will see the word meta-analysis. So in science, in medical science, we pay a lot of attention to the type of evidence and data that we use to make our decisions. And those are important decisions to help you and counsel you. So at the lowest part of the pyramid here, like the lowest level of evidence is an expert thinking something or saying something, what we call an anecdote. So even if someone is a great doctor or an amazing expert, at this stage, if an expert thinks something, it's still very low-level evidence. It can be the start of new knowledge, but it's not strong evidence. Then, as science evolves, we start publishing a case series, so a story of one patient, and then maybe a series of many similar patients about the topic or a treatment. Then we move on, and then we have what we call case control studies, where we compare a group of patients to people who do not have the condition or do not try the treatment. Then we can have bigger studies. So the number of people is very important too in science. Something we see on 5 people versus 10,000 is not the same. Then we have the famous randomized control trials. So those are studies where we compare a treatment usually against a placebo, because we know if we just give a sugar pill or if we do a fake injection or a fake treatment to someone, something that is not active, it can still help the person by the mysterious ways of the mind. So it's very important to compare treatments to placebo in as best as is possible. And then when you have a lot of different trials, all right, so let's say 20 studies, 50 studies, 200 studies, then we can analyze them, put them all together, and see if they all go in the same direction. Do they tell the same message, or are they saying discordant thing? You know, are we sure we can recommend to the medical community to prescribe this treatment or to test this blood test or imaging? So this apply to all areas of medicine. So a guideline is usually based on a review of the scientific evidence. We want to know, is it good evidence? Because even if there's something published in some journal, it doesn't mean it's good. And based on that data, it's very important to have the facts. You know, in this society, in this era, in this world, there's a lot of talk about alternative facts, about fake news, about what is truth, what is not, what is an opinion, what is a fact. So, what can we confidently recommend to healthcare providers? And so, why are guidelines so important? It's but because when we have guidelines, they become a bit of the key reference, the gold standard, the thing that we will use to teach future doctors or nurse practitioners or pharmacists. We use it to teach to practicing clinicians. We use them to argue and advocate with insurance companies to tell them what is the gold standard, what is the standard of practice in a given area of medicine. And of course, we share it with you, with the people, the patients, to tell them what their expectation, what your expectation should be. What should you expect from a given provider to receive what as a treatment based on current science? So it's really a guide, and it's an important guide for you and for your healthcare provider. How are the guidelines done? So actually, it was a big effort. I show you here two pictures, Dr. Susan Christie and Dr. Johanna Medrea, because they were the pillars of this work. It was 6 years of work. So this thing takes a lot of time. It's mostly volunteer. So there were the lead authors here that you see. So I'm very grateful to them. But there's also the whole team of experts that work on the recommendations. So they reviewed the data, they evaluate the quality, they put the experts together, they coordinate the whole thing, and then they make the recommendation, they write the whole text, they review the whole text, they send the text to the journal, and here it is for us to discuss tonight. So thank you for everyone who was involved in this very, very important work. All right, so now we dig into the document. The first part, there's actually two parts, and the second part is subdivided in two parts. So the first part is really looking at what we call evidence-based recommendations based on the quality of the evidence. So for this part, the studies were reviewed. So new studies we have since 2012, because our past guidelines were there since 2012. So a little hint, it might be that this will be the document that we use to guide our action for the next 10 years until more new treatments are available. So which drug can we recommend? And for the first time, we separated episodic migraine from chronic migraine. Episodic is less than 15 days of migraine per month, and chronic is more than 15 headache days per month, of which 8 are clearly migraine attacks, and then since more than 3 months. So those are criteria that we use in the international classification. In the part two, then we focus more on clinical questions to guide our colleagues in the physicians, nurse practitioners, and pharmacists. So we ask who should receive prevention, what is an adequate trial, what we look for when we consider a preventive, and what is a good goal? You know, what is a positive outcome? When should we find that the treatment is effective? And if it works, how long are you going to take it or to receive a prescription? And then there are some clinical strategies and clinical considerations that are discussed on CGRP antibodies and also pregnancy and breastfeeding. So this is quite of a dense document with a lot of information. I give you just, don't read this, it's fine. It's just to show you how detailed how much detail there are in this presentation, in this guideline. You can see all the names of the studies, their findings, how many patients there were. So for each study, all of this was taken into account. And then table 6 is the actual guide, and I suspect a lot of healthcare providers will use that guide, where you can find the name of the treatment, of the medication in this case, the level of recommendation and level of certainty for recommendation for episodic and chronic, and then the dose, and then the common side effects, and then also some cautions that we make for clinicians prescribing these drugs about, what type of disease, for example, of other problem or health issue should be considered before this is prescribed to someone. So this is just part of the table. The table includes a lot of medications, but I just wanted to show you a bit of how it's done. So to just remind, there might be some new people who begin on their path or their journey. Some people have never tried preventive tonight. Some of you might have tried a lot of preventives already. But overall, migraine management is separated in what we call lifestyle and behavioral changes. So how to kind of live and stabilize your brain with different habits and stabilizing other aspects of your health, like diet, exercise, stress, and sleep. And then acute treatment is as needed when you want to treat the attack. And prevention is to lower attack frequency and severity. So prevention is anything that you do. It can be a treatment, it can be a device, it can even be a practice that you use to decrease the frequency and severity of migraine. Okay, so now we dig into first, I'll do the reverse. I actually will present a few things from the second part and then talk about the drugs. Who should be offered prevention? This is really something in evolution. I can tell you in my own practice, I'm not practicing the same way that I was practicing 15, 10, or even 5 years ago. So there's 3 recommendations. Patients or people who have 4 or more moderate or severe headache days a month not responding to an acute medication. So that means that, for example, let's say you have 6 days of migraine per month, but it's very easily treated with a triptan or anti-inflammatory. Well, maybe that's okay. Maybe you can function like this. But if it's not responding and it has an impact on your life, then you could consider prevention. If you have 8 days per month, or approximately 2 per week, of any attack, treated or not, even if the treatment is effective, you should consider prevention. Because at this frequency, we know there's a higher risk of getting worse, or chronifying, we call it, becoming chronic. And there's also a risk of medication overuse headache if you use a lot of triptans or other types of therapies for acute treatment. So 1 per week if it's severe, 2 per week at all severity. But even if you have 3 days per month of migraine and you have an impact, you could consider prevention. And it's not written, but anybody who has chronic migraine should be offered prevention. And I would say very proactive prevention, because chronic migraine is severely disabling. Some of you might be a bit surprised that, wow, only 4 days per month. But then one thing we are learning with the time is that the burden of migraine goes way beyond the actual migraine days, because there are different symptoms before and after the attack. There are symptoms in between attacks. There's also this kind of living in between the migraine attacks where you need to avoid a lot of things. You cannot do this or that. You cannot eat this or that. You might fear the next attack, and then you need to catch up, and you need maybe to take some medications that give you side effects. So at the end of the day, in the iceberg on the right side, well, for only 6 days of migraine per month, you could have a few days of prodrome, canceled plans, catching up days, lost weekends, maybe an argument with your partner, maybe some tension with your coworkers. So the burden of migraine is really more than just the days per month. And I think now we're talking more and more about trying to have what we call migraine freedom. Migraine freedom could mean 0 day of migraine, or it could mean days of migraine, but very low burden. Like you cope well, you're confident that you can do things, and you can treat attacks. A lot of patients I meet in my practice have 4, 6, 8, 10, 12, 20 days of migraine per month, but still they are very reluctant to try prevention for all kinds of reasons. Most people don't like drugs. And one other thing is that people want to treat the root cause, the cause of migraine. It's a fair question. And so, usually, when you live with migraine, you will go in those places where you hear about all kinds of different things that influence migraine. So, sinuses, the weather, hormones are very talked about these days, the diet, right? Maybe you're trying to find a proof that you have migraine, like an MRI. Maybe your chiropractor tells you it's all about your neck and maybe you can fix the neck. I'll tell you, it's very rare that a neck can be fixed. So at the end of the day, the migraine is more than just one cause, very most of the time. It's actually a neurological disease. I've shown this slide before, but it just, and I'm not going to go into detail about it, but it's just to tell you that migraine is a disease of an interaction between the brain that is genetically different and that reacts to the environment. And that's why there are so many factors for everybody who lives with migraine. So we know a lot more about the brain. We know about the chemistry of it, the electricity of it. We know about peptides, serotonin, energy metabolism, all kinds of things that we find on testing, but not testing we can use in practice. So prevention of migraine for now is using drugs to stabilize your brain. One thing I want to say is that CGRP blockers, which you will see in the guidelines, are a new drug. It's a new advance in migraine treatment, and it really changed the way we think about migraine care overall. Because in the old days, anybody who's been to a migraine clinic, the first step was all about lifestyle triggers, right? Can you avoid your trigger? Can you manage your stress, your anxiety, your exercise, your sleep? It's true. But now that we have like drugs that are more effective and more specific, that they treat one of the causes of migraine, well, sometimes I ask myself, how long should this person avoid this food, not exercise, manage everything and monitor everything instead of just treating the disease and live better without having to do all of this. So my point here is that medical care is essential for migraine. And I say this because I see my fair share of patients who have waited so long to try medications. So in summary, migraine management is not only about the drugs or the medications, but it is also about the drug and the medications. So it's really a balance between lifestyle and medications. Okay, so now let's talk about the guidelines and the medications and the recommendations. The group in the guidelines, they have made evidence-based recommendations with two different strengths. So there are strong recommendations and weak recommendations. So a strong recommendation is when the group of experts is confident that the treatment can be used for most patients and that the benefits of the treatment outweigh the potential risk. Let me pause a little bit here because there's many words here. It means that if we recommend a therapy, we think that the data supports that the therapy is going to help more than harm. So it doesn't mean there's no side effects at all, but it means that the benefits outweigh the potential risks. And that's really typical of the Canadian guidelines. Other guidelines do not pay a lot of attention to the risk or side effects. And I think that's a strength of our guidelines. Weak recommendations is when the experts think that they're less confident that the desirable effect outweigh the benefit outweigh the risks. So that means, for example, and you will see when I show you the slide, that a drug could have good benefit, but high risk of side effects. So that would be a weak recommendation. Or it could be well tolerated, but there's not a lot of proof that it works very well. Right? So it's always weighing benefits and risks, not only looking at how many studies were good for that drug. I'll start with the supplements and nutraceuticals. A lot of my patients, they prefer to start there. Because supplements and nutraceuticals are seen as more natural, they're usually well tolerated. So here you have the recommendations updated. Magnesium, vitamin B2, coenzyme Q10 are strongly recommended, partly because they are, yes, effective, but also very well tolerated. Melatonin has been added with a weak recommendation And then butterbur or Petacitis hybridis is now, it had a strong recommendation in the previous guidelines, but in those guidelines, it has not been reviewed because there's been some concern about safety for the liver. There's one sort of Petadolex that is safe of butterbur. It's called Petadolex. It is approved by Health Canada, but some formulations that you can find, for example, in natural product stores may not be safe. So because of that, and because we wanted to make sure about your safety, the guidelines do not strongly recommend anymore the butterbur in all its form, but Petadolex is an option. So we can talk a lot about supplements, but those are the recommendations. Okay, so this is the key table. This is probably what we're going to teach again and again and again to healthcare providers in Canada. So you have 10 strong recommendations for the prevention of episodic migraine, right? So not chronic migraine, episodic. We have data for people who have less than 15 days per month of migraine. In blue, I put the new ones, the ones we didn't have in 2012. In green, I put the ones we did have in 2012 that were kept the same level. And in purple, I put one that was actually in 2012, but now has been upgraded to a strong recommendation. One is not there anymore. It's been downgraded. It's the pyramid. You will see it in another table. So here, first, a few comments about this table. Amitriptyline, atogepant, candesartan, all of this. It's alphabetical order, okay? This is not the order of priority. This is just alphabetical order. I did not add the quality of evidence there because it's in the table 6 evidence. And the supplements I just mentioned in the slides before. I did put the brand names also. So here, amitriptyline is an antidepressant called Elavil. Atogepant is a Gepant called Qulipta. Candesartan is a blood pressure drug. It's called Atacand. And then we have our 4 antibodies, eptinezumab, which is Vyepti, erinumab, Aimovig, fremanezumab, Ajovy, and galcanezumab, Emgality. And then we have 3 drugs that we call beta blockers that act on the blood pressure as well, metoprolol, nadolol, and propranolol, and you have the brand names on the right side. So this is usually what we would strongly recommend for the prevention of episodic migraine. What are the weak recommendations? So those are the ones, that are probably not good primary care first choices. They may be good for selected people. In purple, and this is my opinion, this is not the guideline, the thing in purple, I think most of my colleagues would agree, but so some are effective but poorly tolerated. So we have the valproex, flunarizine, pesotifen, and topiramate. Actually, the topiramate is an anti-epileptic. Pesotifen is something that works on serotonin, and flunarizine is a drug for also blood pressure, and the valproex is also an anti-epileptic. And then we have other drugs that are maybe effective, but well tolerated. I'm not going to go into great detail about those, but they are blood pressure drugs, anti-epileptic. Memantine is a drug for Alzheimer's disease. A little note here about rimegepant, Nurtec. You hear about Nurtec is a Gepant. It's a drug that blocks CGRP, just like the antibodies. But Nurtec is given in Canada for acute treatment of migraine. It is not approved in Canada for the prevention of migraine, but it has been studied for prevention, and it is prescribed in the United States and some other countries for prevention. So this might be confusing, right, for you, for healthcare providers, for a lot of people, but at present time, Nurtec in Canada is indicated for acute treatment only. But in our guidelines, we look at the evidence, and so the evidence exists for a preventive role, but with a weak recommendation. You will notice here that topiramate has been downgraded from a strong recommendation to a weak recommendation. It's important because topiramate, most of the providers who prescribe it, we know that it has a lot of potential side effects from difficulty thinking, speaking, kidney stones, and different issues, fatigue, nausea, dizziness, and so on. So it can be extremely effective, but it has a lot of side effects. So that's why it's a weak recommendation. Now, in some provinces, including Quebec, topiramate is still recommended like a mandatory trial before trying the antibodies or Botox or other things. And so we're going to work on it just to say that this drug now should not be a first line drug anymore for migraine. So I think that's very relevant. Now we shift gears. We leave the world of episodic migraine. We go to chronic migraine. So the most severe form, 15 days per month, since more than 3 months. So let's look. We have a lot of novelty there because in the past guidelines, there was nothing for chronic migraine, right? It was barely just described in 2010-11. So in 2012, when we had the past guidelines, there was no section on chronic. So you have all the antibodies, the atogepant as well, Qulipta, Botox, and propanolol, Inderal, which is also given for episodic migraine, and a weak recommendation for the pyramid. So in theory, if you look at this, for chronic migraine, very quickly we should move on to the antibodies or Qulipta or Botox, because that's where the evidence is the best. There's actually no evidence that Elavil or amitriptyline works for chronic migraine. It's an old drug. Chronic migraine was not defined in those days. So it's widely used. It's been prescribed for decades for chronic migraine. It's just we don't have evidence for it. So at present time, it's not recommended, but I would say it's widely used. There's also a few that are just not recommended. So we recommend not to use it because there's evidence it does not work. Ginger as a supplement does not work. May be good for nausea, but not for prevention. Gabapentin was previously weekly recommended, and then now it's being downgraded. It's not recommended anymore. And statin, that are cholesterol meds, for example, Lipitor, Pravachol, are not recommended. Okay, so I know I've given you a lot of names of drugs, and this is the job of your healthcare provider is to guide you in all of this and to advise you. But we all know that providers sometimes do not have the most recent evidence. So I think having the tables is a good thing to kind of understand a bit what options are out there, how many options there are, how many drug classes there are. But how do you choose which one you are going to try? So I don't know. I don't like to shop for jeans because it's so complicated to find the one that fits. But it's a bit similar, okay? So you have to decide the color, the wash, the size, and then is it going to fit you or not? So when you try a drug for prevention of migraine, you look at effectiveness. Is it a strong recommendation, a weak recommendation? What's the evidence that it's going to work? Then the side effect profile, what are the side effects of this drug, the common ones, the rare ones? Is it good or bad for certain other things, other diseases you might have, depression, anxiety, obesity, hypertension, constipation, vascular issues? And a lot of people with migraine have other conditions, so it's important to look at. Then your level of disability and the severity of migraine. Sometimes when there's a lot of burden, we're going to be more aggressive and say, okay, let's go with a drug that maybe has a bit more side effects, but really could help you. And pregnancy planning is another important thing. So to summarize here, I actually had prepared cards for all the drugs with all of this, but I realized it would be way too long. So I'm happy to share that some other day with the community. But roughly, when you get a prescription, you should probably know, the mechanism. A lot of patients are interested in that. What type of drug is it? What are the cautions or the contraindications for it? What are the common side effects, the rare side effects that you should care about or monitor? And then maybe the other side benefits. Sometimes we prescribe a drug and you have tremor and that drug is good for tremor. Maybe you have high blood pressure and that drug is good for high blood pressure. So sometimes some of these drugs might actually be helpful for you in other fields of your health. There's a lot of different strategies. For the sake of time, I'm not going to go into all of the strategies, but I'll show you the first time strategy. So that means that in theory, a person who wants to start a preventive for migraine could start with any of these drugs. Beta blockers, so those are for blood pressure. Candesartan, also for blood pressure. But then the CGRP agents like the antibodies and atogepant, those ones could be, in theory, medically, tried first for people who have high frequency migraine, 8 days or more, um, or moderate disability, and chronic migraine. And then Botox should be considered first line in chronic migraine. Now, insurance companies might disagree, right? Those are medical recommendations. And then also amitriptyline can be a first line drug. And then always consider pregnancy plans. Okay, so this is actually in the when you decide what to do, the right time to talk about pregnancy is before you are pregnant. And every provider knows this. When we treat, females that could get pregnant, I always ask, is pregnancy on your radar? The minute you think about it, you should discuss it with your provider because a lot of these drugs have to be stopped, including the antibodies that stay in the body for a long time. So you have to stop them 6 months in advance. In the guidelines, there's actually a full section on pregnancy and breastfeeding. This is a complicated topic. There's a lot of risk benefit calculations. Botox also can be discussed. So as soon as you think about getting pregnant, you should talk with your provider because that will influence your choice for preventions and the options that you can try. Side effects. That's our favorite topic. I see so many people with migraine with decades of trying and having every side effect in the book. I have to be some people have no side effects. It's difficult to know why, a person will get a side effect and another will not. So advice, this is not part of the guideline, but it's kind of, how we work and how you should navigate this complicated world of options. Discuss your concerns and priorities with your provider. You know, uh, be like share what your concerns are. And some things might be for you completely, yeah, you don't want to take that risk for a side effect. And then other side effects might be more acceptable. A little note, be aware of social media, and I will include patient groups. I'm not saying that the people who share their experiences on patient groups did not have side effects. They did, but negativity is overrepresented because people who are, happy with no side effects sometimes are less inclined to share that on a group. So sometimes we have an impression that 90% of someone who tries the drug will have side effects, when in real life it's 1% or 5% or maybe 10%. So I want to encourage you with these drugs to consider giving it a try. If you decide to go ahead, start low and go slow. So for drugs that can be increased, collaborate with your pharmacist and check for a backup plan. So the key point here is that all migraine preventives have some side effects. Some may have more or different types. So get informed, make your decision, and go monitor and decide if you want to stop. So that's a question that's been discussed in the guideline. How long should you try before you say, okay, that's it doesn't work? If you have side effects, obviously you will stop it early, right? You might decide to tough it up a little bit, but then if, let's say, after 3 weeks or a month, it's unbearable, you cannot, the side effect is too hard, then you can stop, that's it. But if there's no side effects or very mild ones, you could say, how long should I try? There's no official recommendation for supplements. So here I put 3 months. This is not what the guideline says because there's not a lot of clarity about this. But in general, I treat supplements as other medications, and I say, well, we try them for 3 months. Oral medications, except atogepant, should be increased progressively, like according to the start low, go slow technique I mentioned. And then once you reach the good dose and optimal dose, then you should, at least for 2 months, you should have a diary and look at it. So 2 months or more at the full dose. For Qulipta or atogepant, well, usually we start it at the full dose right ahead. There's no titration. So then 2 months or more. We usually say 3 months, but it depends with the provider and the patient. For antibodies, it's different. The subcutaneous ones, it's 3 to 6 months, so 3 to 6 doses. For the Vyepti, which is IV, it does last longer. So usually if you do 3 infusions of Vyepti, it's going to be 9 months. So 6 to 9 months is a trial of Vyepti. And for Botox, it's 6 to 9 months as well, because Botox is injected every 3 months. So according to the guidelines, you really have to do a good trial according to these durations. What is a good response? So that's another question that the experts in the guidelines do tackle. The key goal usually is getting better by 50%, right? I put some grids from the Canadian Migraine Tracker on the right side. So you would see on the top, you see someone who has 2 days per month, and this person is one of my patients who actually started with 18. So that's more than 50%. That's actually a super response, all right? So 75% better is a super response. 50% better is what we aim for. So that should be that's a realistic approach. But now with some of the drugs we use, we have 75% reduction rates. And then if you have chronic migraine, 30% reduction is significant because if you have a high number of days, well, if you remove 30% of 21 days, you still gain 7 days back. So you can see at the lower side, the grid, this person there, also one of my patients, has a lot of actually no headache-free days, starts from very severe states. Sometimes we will use also scales and questionnaires like HIT6 or MIDAS, which are also in the Canadian Migraine Tracker and our website. So those are questionnaires that we use sometimes, for example, with the insurance companies or just with you to see if your score is getting better. And obviously, a good response is a good benefit with no side effects or side effects that can be tolerated. So here is an example of super response. This is one of my patients who's a nurse, and she has tried previously 6 oral preventives. Then she tried, this is a CGRP antibody super response. And then she went from, 17 to 23 to 3 to 7. So that was really a great response. So we hope for this, but sometimes we cannot reach this. So 50% response is still the thing that the guidelines will describe as a valid response to a preventive. Another thing that we discuss this is something that it's more of a problem with insurance companies. So I wanted to touch about this as optimal care and updates. Is that if you look at this patient on the top, if you look at the little circles, there's a lot of red and orange in there, not a lot of green. And with the treatment on the prevention, lower, then you can see that there's way more green. So she still has no headache-free days, right? She's still at 30 over 30, but the intensity is way better. And that's something we've learned also is that it's not only a matter of frequency, intensity matters, but it's a bit of a challenge sometimes with the insurance companies to explain that to them. All right, so beyond the frequency, there's the intensity. You might also want to record the needs for acute medications, a better response to acute medications. Maybe there's an impact on your mood, your sleep. Maybe you actually have a bit of a decrease in frequency, but you're doing way more things. So you can travel, you can exercise, you can do your social things, see your family, you can work better, even return to work. So we really, I think in the next guidelines, they're going to be more about all this world of beyond the frequency. But for now, we stick to the frequency as a first basic outcome. Okay, then the question, this is in the guidelines regarding the duration of the intake. What if, and that's the question all of my patients ask me, especially if they're younger, they will say, am I going to take this for life? Well, migraine is a chronic disease, right? It is not like a cancer or an infection that we can remove from your brain. There will be fluctuations, and yes, there can be significant improvements. So here you can see on the little circles of this patient over a year. So this person moves between 6 to 13, 15. So it's on and off, right? So some people, even with prevention, will still fluctuate a lot. So usually what is recommended now in the guidelines is that if you are stable, but stable can mean a lot of things. So it could be, for example, 4 to 6 per month. Because according to the guidelines, if you are at 4 per month, you should consider therapy. So if you are above that, maybe it's a better idea not to stop the preventive. But let's say that you find yourself very stable, it's possible to decrease the medication. If it's an antibody or Botox, it's recommended to space the treatments. So let's say Botox is every 12 weeks. You could say, okay, I'm going to try every 14 weeks, every 16 weeks. And then if you stay stable, you could stop the prevention. The same for antibody. Let's say you have it every 4 weeks, maybe every 5 weeks, every 6 weeks, nothing happens, you're very stable. Maybe you don't need prevention anymore. Usually, I do recommend to never stop anything abruptly, even if it seems like it doesn't work anymore, because sometimes it will get even worse than it was. So this question about the duration of intake of the preventive is addressed. Now, a few words about coverage, and thank you for our executive director, Wendy, to provide this. So, roughly put, CGRP antibodies are now covered by public drug programs in all provinces for three of them, so HOV, Emgality, and Vyepti. Unfortunately, Aimovig is not covered easily in any province. So sometimes we can do like special authorization forms or special patient exception forms, but it's not easily accessible. And I say it's too bad because really they were first in class. And for some reason, they have been stuck in a status where they're not covered. When in the end, the effectiveness of Aimovig is very similar to the other antibodies. Qulipta, it's coming on. We're working very hard on this to have it covered by the public systems. And Botox varies in some provinces. It's easier to access than others. For example, RAMQ will pay for Botox, but with a special form. For private coverage, it varies a lot with the plans. So usually antibodies, Qulipta, and Botox will be covered by most insurers if you have tried two other drug trials, right? So two other classes, usually amitriptyline, a beta blocker, topiramate, or maybe now candesartan. So hopefully no more topiramate and more candesartan, but we'll see. A question I hear a lot, can my GP prescribe this, the antibodies or the GPANs? Yes, they can, right? There's no restriction to neurologists. So any physician who has experience with treating migraine can. The thing is that GPs are, they have so much to know. There's a lot of new things in primary care. So for them, they're so busy sometimes that adopting new treatments might take a bit of time. The paperwork that goes with all those insurance forms and patient support program is long. There's a ton of need for education. So the Canadian Headache Society and Migraine Canada, we work on this. It's a work in progress. But if you do have a GP and you feel that the GP wants to learn more, seriously, bring them the guidelines. You would be surprised that GPs, they cannot monitor everything. So maybe they don't know the guidelines are out there and they will be happy to know that they are. I hope they will be happy because they're great guidelines. Okay, so should you combine preventives? This is also discussed in the guidelines. And here I just copy and pasted what is said. So you can layer different treatments. It can be considered in refractory patients. And it makes sense from a medical perspective. We do combine drugs in every field of medicine. Drugs might come assist one another a bit like you build a wall brick by brick. And then it might be that some drugs go well together and they protect you better to reach optimal success. One combination I have to mention, and it is also mentioned in the guidelines as a possible combination, is combining the toxins, so Botox with CGRP, so an antibody, or a GPANT. And I usually don't show graphs in such presentations, but here's just to show you the response rate if you have just Botox in blue, just the antibody in green, or in purple, you have both. And it's clear that the 50% response and 75% response rate are way better. Way better. They are better if those two are taken together. Now, insurance companies are really struggling with this. They find it's very high cost. Now, chronic migraine is also very disabling, very costly. And so this, you might discuss this with I would say your headache specialist. I don't think any GP would do this, or even general neurologists, but this is something that is on the horizon as a potential combination. Now, it might be that you have tried a lot of things and that nothing so far has worked, and that you find yourself in this refractory category. This is a little graph so you can see why is this happening. maybe for you, the cause, maybe the peptide, maybe there's a biological kind of that there's something in the migraine pathophysiology or the cause that is different. It's possible. The other thing we see a lot is that some people with migraine deal with a lot of other health issues, inflammation, other pain, blood vessel issues, intestinal health, mental health. And so sometimes the load, like the burden on your brain, is just very heavy and it's difficult. So the migraine cannot quiet down because there's so much happening in your body and sometimes in the mind as well. So this leads to sometimes very difficult situations. Another thing is that migraine is a disease of the brain interacting with the environment. Some of my patients, they don't get better, and it's obvious they're under a lot of stress, family members being sick, financial issues like war or, like people like immigration or all kinds of, severe psychosocial stressors can impact migraine. So there's all kinds of reasons why a treatment might not work, any of these treatments that I've shown you, and that definitely exists. If that happens, then we go back to square one. We readjust lifestyle, natural approaches, behavioral approaches, therapy, and then you can go on our website and find more information about this holistic approach. So, a last note before we finish and I take some questions. These guidelines are for those of you who have a diagnosis of migraine. They are not for what we call secondary headaches. So headaches that are caused by a trauma, an accident, a concussion, a tumor, an infection, or other things like new daily persistent headache. If you do have headaches that look like migraine, but they are caused by all these things, infections, tumors, and inflammation, and trauma or surgery, for example, um, well, they're still in the headache community. We often say if it looks like migraine, maybe treat like migraine. Maybe it's the same chemistry, maybe it's the same peptides. So you will see sometimes headache specialists will try migraine drugs in people who have headaches that are caused by something else, but they look like migraine. Those guidelines do not look at the evidence for, there's actually not a lot of evidence that, for example, CGRP antibodies work for post-traumatic headache. And there's virtually no evidence for any of these drugs for a lot of other types of headaches. But in the absence of evidence, sometimes we will consider these drugs for other types of headaches. But these guidelines are really based on evidence for people with migraine. So at the end of the day, I think those guidelines are going to be very helpful, but still the journey of the person with migraine is very long and there's many steps, and you know this. But it's important that we advocate for better care because the first step is for you to seek care, but then you have to find a doctor. You might have to find a specialist and wait. Even getting a diagnosis is actually not that easy. And then do all the lifestyle thing. So maybe we spend years doing the lifestyle and maybe it should be shorter. Uh, Deciding to try the medication, getting the prescriptions, finding medications that work, and then getting medications covered. A recent study showed that in Canada, barely one person on 10 actually makes it to a doctor, a diagnosis, and an appropriate prescription for migraine. So there's a lot of improvement that we should try to do because now we have the drugs. It's just like the drugs should be accessible to the people who need it. So I encourage you to, ask questions, seek the care, spread the word, etc. So what are we going to do about those guidelines at Migraine Canada? Well, first we're going to have a position statement about them and comment on them. We'll summarize them for you guys in hopefully a one-pager. It might be a two-pager. We'll see. We also are going to disseminate and promote them to the government, the insurance companies, the healthcare providers, and of course, you. And we will try to stimulate and involve you in engaging the community to share them, talk about them, answer questions, and make sure that they are known and that the level of care in Canada increases to the best. So you can access medications that might help you. So share the word, as I said, get the PDF, share it, share it, share it, talk about it to your healthcare provider, to your pharmacist, bring it to your pharmacist. Is anybody tonight brings those guidelines to the pharmacist, you will have done a great thing. So this is the end of the presentation. I thank you for listening. You might have questions. I will remind that I can answer certain questions. I do not answer detailed questions about particular personal cases. That would be inappropriate practice of medicine. And Kaylee will moderate the discussion. So I'll stop sharing. Okay, here we are.
Thank you, Dr. Leroux. I'm going to go back to sharing my screen. And just quickly before we move on to our questions, I just want to quickly let everyone know that we thank you for your time, for your interest in joining these webinars. And before we go to the Q&A, we do hope that you found tonight's presentation informative and valuable for yourself. We do have an ask for this Giving Tuesday. If you are considering donating to any charity, please consider donating to Migraine Canada. We are a registered charity, and any donations received do go towards our programming. One of our programs are these webinar series. And with that, Dr. Leroux, we have a lot of questions. And the first one I'm going to ask, I actually received via email. You did mention it a lot, recommended people take these guidelines directed to their primary care provider or even their pharmacist. But otherwise, do physicians typically receive through any network, any means, these updates, or is it the responsibility of patients, or if it's a personal interest of physicians to stay updated?
So very good question. It is the responsibility of the doctors to stay updated on topics relevant to their practice. So, for example, there's not going to be like the College of Physicians of Canada sending this to anybody. So we will offer, the Canadian Headache Society just had their first event in Toronto recently, and we did offer a presentation of the guidelines. So the Canadian Headache Society will really strike hard to offer training, offer presentations. The pharmaceutical industry will disseminate them. But to be honest with you, reaching out to family practitioners is very difficult because they are really solicited. And that's where it shouldn't be the responsibility of a patient to do this. But at the end of the day, GPs are so in demand and there's so much novelty, and there's no official network, even for something like this that touches a lot of people, to be disseminated. Like GPs do not read the Canadian Journal of Neurological Sciences. I can guarantee you that. And so we know from previous guidelines that the level of awareness that the guidelines existed even years later was less than 30% of GPs. They didn't even know they existed. So I think that we need to work all together to make them known.
Great. Thank you. So I'm looking in the Q&A now, and there were several questions about these guidelines. Are they specific to migraine? And at the end of the presentation, you did confirm that. But somebody did ask about nutraceutical supplements, if they are recommended equally for migraine and non-migraine headaches, or same situation, should a physician treat this other headache type like a migraine and try the nutraceuticals?
So there is the same. There's no evidence that I'm aware of these for these. Migraine is the bigger, it's the most common, it's the better studied condition. So that's really why. So there's not, to my knowledge, I'm not sure there's any study on nutraceuticals for other headaches. Now, nutraceuticals are so well tolerated and usually harmless that it's okay to try them. The problem is that at the end of the day, they do cost quite a bit of money. They're not always covered, and it's a bowl of pills. If you take all of them, I'll give it a notch that there are some compounded. So, for example, there's one that's called Migraine MD at Naturals. That's produced by a neurologist in Canada who decided to go in business and create a compound. There's tree grains, there's like a mig relief. So sometimes I do recommend, like instead of trying one and then the other and then. So when it's supplements, you can sometimes pack them up all together and try them. But it varies a lot between patients. So personally, would I recommend anybody who has a post-stroke headache to try supplements? I wouldn't because I don't think they will work, but I see no harm in trying them.
Okay. Thank you. Next question. Is there hope that current and future studies will include geriatric patients with chronic migraine?
That's actually a great question. And I will underline that with some of the studies for the antibodies, it was over 70, up to 75. And with atogepant, we have data until 80. So that's Qulipta. So I think now the industry has heard the message and they are trying to include more and more patients who are above 65, above 70, and even up to 80. And we also have a first trial ever in pediatrics that's been revealed for HOV from anizumab in the pediatric community that is positive. This was released in the paper is not even out there, but the results were shared in London, UK. So it's also very encouraging that now we have a strong corpus for adults. We'll have more and more for kids and also for elderly people.
Thank you. Somebody else has asked about CGRP antibodies being available and approved for children.
So that's where we are. We have this one trial, and I really I think it will be published very soon. There are many other trials underway in pediatrics, and I think now the wall has been broken. I think now we're going to see more and more trials, hopefully with positive results, because the last big trial we had in peds was the CHAMP trial with amitriptyline, topiramate, and placebo. And unfortunately, it was a very well done trial. It was completely negative. Like the placebo was actually better because it was better tolerated, but the results were the exact same thing. So this was a bit of a cold shower for our colleagues in pediatric headache. But now with this firmanizumab HOV trial, we're encouraged and there's more to come.
Okay, exciting. Somebody else has asked for chronic migraine. If amitriptyline is no longer given a strong recommendation for prevention, would that also be true of nortriptyline?
That's a good point. So first, it's not given a recommendation. It's just there's lack of data for chronic migraine. I would say based on decades of use, I think most experts, but remember this expert opinion, I said it was the lowest level of evidence, but we still have a lot of experience with it. So I would say most experts would still use it in chronic migraine, and the same goes for nortriptyline. Nortriptyline is a funny little thing because it's like the unknown cousin of amitriptyline. A lot of us think it's better tolerated and also effective, but there's very limited data. So I think we all use it, but that's why it's not in the guidelines that there's limited data on it. But I certainly personally have seen, once again, expert opinion, cases where, like amitriptyline was not tolerated, and then we tried nortriptyline and it helped.
Okay. Next question, and this one was submitted a while back, so my apologies if you did address it later in your presentation, but someone has asked, what about Ubrelvy? I didn't see it mentioned.
Oh, very good observation. So Ubrelvy is not a preventive, but that's where we go in this muddy zone of GPANs because GPANs are acute treatments and preventive treatments. And now they're going to try Qulipta for acute treatment. So it's messy because at the end of the day, if you take a pill to block CGRP and you take it very often, then it becomes a preventive. So this class is really a bit of a revolution in our concepts of migraine, and that's very normal to wonder why Ubrelvy is not there. So Ubrelvy is only for acute. Nurtec, I mentioned, only for acute in Canada, but used for prevention in the US. And it's a moving target, like I said, because now we're going to have maybe Qulipta tried as an acute. Who knows? It's evolving very quickly.
Okay, there were some people who mentioned in the chat that they just didn't have the Q&A function, so I quickly jumped over to the chat as well. And there were some people asking about vestibular migraine. So is that part of these migraine guidelines, or is that other headache separate?
Yeah, it's one of my favorite topic, and I will. There is a webinar I gave on vestibular migraine. It's on our YouTube channel. Um, so vestibular migraine first is not an officially recognized entity. It is still in what we call the appendix, which is like the side closet of the classification. But it's rising. It's rising. Most people are more and more people are recognizing that it's a clinical entity. And there's a recent positive trial for Emgality, galcanezumab, positive in vestibular migraine. There's also other pieces of data showing that Botox and antibodies are effective. There's also pieces of data for venlafaxine, which is a Effexor, which is a weak recommendation, and also calcium channel blockers like flunarizine or verapamil, also weak. So that's a perfect example, actually, where a weak recommendation could become a strong, like a good idea for a person. If you have vestibular migraine, you could consider something like flunarizine, verapamil, or venlafaxine. So more details. But yes, and I was very encouraged by this trial of galcanezumab for antibodies. So more and more experience is coming on vestibular migraine. Even how we research it is complicated because you need to look at the headaches, the dizziness, the vertigo attacks. So it's a complex entity.
Okay, thank you. Excuse me. Did you may have mentioned this, someone's asking, what are some preventives and acute medications available for pregnant women? Is that included in the guidelines?
Yeah, it is. So there are some, this is a sensitive topic, right? Because we're very careful with pregnant women. So there are recommendations in the guidelines. They are not as detailed as other, for example, the Spanish Headache Society has published recently a very good review for pregnancy and breastfeeding with recommendations. I think it's also free access on PubMed. So usually what we will do is propranolol is usually a kind of the first recommended drug for prevention during pregnancy. Amitriptyline low dose is another. And now there's more and more reassuring evidence for Botox. So I'm not saying it's recommended. I'm just saying it's a discussion you can have if you have chronic migraine and you're planning a pregnancy to go on Botox. Antibodies are a no-no so far. Gpan, the same thing. And topiramate, an absolute no as well. It's teratogenic, it's dangerous. So this is an important discussion. And yes, there's some guidance in the guidelines, roughly around the lines that I just mentioned. And then, like I said, there's this great Spanish paper that is in English that provides more detailed information for this situation.
Okay. What about pediatric migraine? Are there guidelines or updated guidelines?
So at present time, there are no updated preventive migraine guidelines for the peds that I'm aware of. Migraine Canada has issued a great two-page document to guide parents. Actually, the idea was to help the parents to discuss with their healthcare providers to give them what is currently on label in Canada and recognized as safe for our little ones. Most of the content, though, is about acute care, so acute treatments, for example, which triptans, which NSAID, what the dose, and so on. For prevention, in part due to this, like this cold shower SHEM trial that was negative, the prevention in children has been very restricted so far. So we'll see with the CGRP blockade in kids if this changes. But at present time, it's very limited. There are guides for acute therapy, but for preventive, to my knowledge, it's very limited.
Okay. Thank you. I did provide the link to the pediatric dosing guidelines.
Yeah,
in
it's
our
a great
chat.
document. With so much work put in this. It all started with a friend of mine who's a pharmacist, Ariane, by the way. Thank you, Ariane. And then the team just gathered and it worked very well. I know some parents, they bring this to their docs, and I've seen sadly some docs just brush it off. but believe it's a really good document and it's well endorsed. I mean, it's really based on what we have, and it's a anyway. Just don't hesitate to bring it to your healthcare providers.
Thank you. Um, and just to confirm, are the new recommendations also helpful if you have migraine with aura?
Oh, excellent question. It's funny how we never I'm even surprised I didn't mention it, but yes, they are. So all these trials included migraine with and without aura. The aura distinction is a bit artificial. It's anchored in history. Aura is one of the symptoms of migraine. It's also a continuum. Like it's not migraine with or without. A lot of people have aura sometimes, sometimes not aura. So that's why now we consider it as just a bit of part of the migraine phenomenon, but not a real distinct category. So all of these studies included patients with auras.
Thank
Apart
you.
from the special auras like the hemiplegic auras, so paralysis aura, basilar migraine, and vestibular migraine was just not described at the time, so it was not quoted.
Okay. Next question. Among the triptans, how different are they? If I've tried a few with meh results, should I try more?
Yeah, that's a very good. We're not in prevention word anymore, but the triptan, there's 7 triptans, and it's approximately 30% to 40% of people who are not triptan responders. So it means that they tried many triptans and either they have side effects or they don't work or both. Now that we have the GPAN, so Nurtec and Ubrelvy, the world has changed a little because we have a different option for people like this. Um, in my personal practice, because I try everything, like the song, I try everything. What was it in Zootopia? I think Shakira, wasn't it? Anyway, I try them all, and I have seen patients who had tried 4 triptans, and the fifth was the right one. So, but now that we have the GPANs, I would say if you try 1 or 2 or 3 triptans and you can get access to GPANs, it would be a decent trial. But if you don't respond to GPANs either, just keep trying. Why not?
Okay. Um, I think I'm gonna go to the chat now, Dr. Leroux.
Yeah.
Oh my
Okay.
goodness, I
No,
didn't
no,
notice the time.
it's fine. You can take one or
I
two more,
forgot.
and then we'll close, I think.
Okay. Yeah, I am
I'm glad to be there. If it's helpful, I'm happy. Those are complex topics. When I teach this to GPs, believe me, I mean, it's not that easy to understand all of those complexities.
um I am trying to avoid the specific personal
Yeah, yeah,
medical.
yeah.
We have a lot of thank yous.
Oh, that's
Um,
good.
yes. I think given the time
Yeah,
and
we're good.
trying to to scan through anyone, if you did post a question that we did miss in the shuffle of the chat or the Q&A, what you can do is email us at info@migrainecanada.org and we'll review your question. But Dr. Leroux has answered a whole bunch of questions tonight, and we really appreciate her time. Um, I think with that, we'll wrap up the Q&A. And again, thank you so much for this presentation.